Thank you, everyone. Thanks for having me here today, and welcome to Introduction to Health Services. This is a course that is taught over an entire module in LSHTM for masters and RD students. It's taught over 12 weeks. So I'm here for 5 days, and we're just brushing. Health services. We're all in the research of it, and we all know that it's a huge topic. We're sort of barely brushing the surface of the course, but I really wanted to give it an overview, and really through the seminars, through our time together, generate some discussions and learn from each other. And I'm very interested about the system in Japan. This course is taught for lots of students, international students in London, and so it's not specific to a country. It's much more conceptual and foundational, and the theories behind why we're working in the different systems. And actually you can apply country-specific examples, and it'd be really good to explore those as we go along together. So why are we studying health services? And I'm just going to put this slide up, I'll just let you read it. And you might find it's quite familiar. Perhaps you can already think of headlines in Japan as well, reading these kind of, these are all just headlines from different newspapers about health services around the world. And you're probably already getting an idea that actually, I can see familiarities. So, I can't read Japanese newspapers, but I wonder if you've got something similar, similar pressures in Japan. Any cuts, any difficulties in payment sources? A nod? No? Yes? Yes? Similar pressures? Okay, great. I think that is, we can really sum it up from that one slide, that we are looking for here in health services a simple but profound challenge. And why is it simple? Well, mainly I think all countries are trying to provide a high quality health system, healthcare, with the limited resources available. It sounds simple, doesn't it? But that's what we're all about. We want high quality, but it's also profound, because what does it mean? What does high quality mean? And also, limited resources available. We're always balancing against all, resources against the quality, against what we can do. And even if we think there are countries that have a lot of resources, spend 20% GDP, like America, on our healthcare, even then, when you are spending that much on your health, you are not spending it on something else. There's always a resource constraint. There's always a limit to what we can do. And also, what do we mean by high quality? Lots of people have probably heard different definitions of high quality. We probably, people use that term quite loosely, isn't it? High quality of this, high quality of that. So how do we define it? And there are many definitions. And in this course, I found to split quality into different dimensions quite helpful. And this is what we want to do. And first of all, I think high quality care should be safe. So Florence Nightingale in England many years ago said to do the sick no harm. So minimally, we want to go into health services, go into healthcare to come out no worse off than when we first started. So safe, one of the dimensions of quality. Secondly, effective. Many of us are looking at the effectiveness of care. What does that mean? Are we doing any good? To do no harm is sort of what we expect, and then we want to go into healthcare, come out better than where we are. So effectiveness. Now that in itself is quite loaded. We're going to explore more of that on the Monday talk when we talk about quality in greater detail. But essentially, it's doing some good. And the third dimension is humanity, humane care. So what does that mean to us? I mean, humanity is quite abstract, isn't it? It's not as automatically obvious, but it's a bit like beauty, or a little bit qualitative. But essentially, what humanity would mean is how you want to be treated. If you were the patient, how you wanted to be treated, mutual respect, dignity, those things. And in different places, call it different things. But humanity sort of encapsulates it all. In England, we look at patient experience. So that is a form of how the services, whether or not they're getting the food, the treatment, they're being covered up when they're being examined, and not exposed unless they are being examined, being treated with dignity. So that's humanity. WHO call it responsiveness. So they call it different things, but essentially is, if you were the patient, how would you expect to be treated? And so, very important. And these three are probably universally accepted as dimensions of quality, of high quality care. And then there's a fourth one, which is equity. And equity is fairness. What do we mean by equity? Essentially is, we are hopefully being looked after based on our need for healthcare rather than any other social dimensions like our sex, our gender, our age. Essentially is that. But, just to be mindful that actually equity might not be something, it is contested, it's not a given. There are countries where it is absolutely within the political and value base to have richer people should have better care. I mean, this is not universal. A lot of social democracies, we feel that actually it should be based on need. But it's interesting, isn't it? So we might all have a feeling about equity for other things, but should we all be allowed to have, big houses, or actually is that not equitable? But actually, when it comes down to health, we probably feel that actually, regardless of a lot of those social dimensions, everyone should be allowed fair access to healthcare, fair health services. And then finally, increasingly in the debate, there's sustainability, and this is quite, not as advocated as the other thought up to date, but I think slowly the rhetoric is changing and increasingly becoming more important in the agenda. And what do we mean by sustainable? Not only financially sustainable, but moreover environmentally sustainable. Now, there's very few research in this area to date, but increasingly we know that it's important with the climate change agenda. Health service activities does cause quite a lot of carbon. If you think about all the transportation journeys, all the treatments we give, all the personnel involved. And this, last year, the NHS in England, National Health Services in England, published a long-term plan. And it's one of the first times that NHS has published a plan, a strategy for the government. And in it talks about reducing carbon emissions of the activities of healthcare. And it really is really increasingly important that we think about the environmental impacts healthcare has. And I think there is some figures suggesting that in the United States, it's about 7 to 8% carbon generated from the activities of healthcare. So it's significant. I think these 5 are really the domains of high quality. And it's just so that we can be mindful that it's a trade-off all the time. We can't really have, all those things, and it's really how we, there's no absolute equity, isn't there? It's really about how much of something we can have given the resources available. So more about quality on Monday. But when we think about health services as well, it's helpful for us to think about it in 2 different ways. First of all, 3 levels. The micro level, a few of us have come from clinical backgrounds, and so actually we all have, haven't we? I've met you, and so you all now had a chat, and so we're probably familiar with in our professional capacity of interacting in a micro level, which is a patient talking to a nurse, or a patient talking, giving you consultations, taking a drug history. As a clinician taking a history, having that, that's the micro level of the patient interaction. Then we have the meso level, which we have a medium level of the organization. So if the nurse works in the district, health district, or in the hospital, and that's that level. Looking at the micro level explains some of the gives us a picture of our health service, which is very important, but it won't give us the entire picture unless we go through to the middle level and look at things from the organizational perspective. Then it explains why there are, why things in the patient interaction happens the way it happens. It gives us another layer of understanding. Oh, why is the doctor spending 5 minutes with this patient and 10 minutes with the patient. Oh, why is he or she spending 2 minutes only per patient? The reasons are more obvious as we go to the meso level, and that's why it's helpful to look at that in the organization level. And then we can aggregate up, and some of us might be working in the macro level soon for WHO, looking at international comparisons, or most often might be nationally. We might be looking at in the systems perspective, so different hospitals together as a country. And so these three levels complement each other, and that's why we want to look at it in different perspectives. And throughout this course, we will visit some of the concepts that happen in the micro level and then builds together a picture in the meso level and the macro level. And then next, we want to consider it from different several perspectives. A lot of us come from a clinical practice background, and because of those reasons, we come into looking at the system as a whole and into health services research. But we must be mindful that we are part of a bigger picture, and actually clinical medicine, clinical practice only gives one perspective to health services. And there are many other very valuable perspectives, and that's why such as the School of Public Health gives us this sort of space to look at it from a sociology perspective, health economics perspective. And none of these can give us a full picture. All of this complement each other. So that's why in this course we consider it from different perspectives as well. And if you were to do this course in LSHTM, there is actually a session dedicated to history. And actually, it's really interesting, and you can think about it for your country, how actually our health services come to be because of historical influences and how the cultural contexts play into it. And that's very fascinating, and not to undermine why things are. We always think it's science because it's scientific, or science-based evidence. Well, actually, if we think about it deeply, how much of it is actually cultural, belief, and also historical.